Hello, my name's Kerry Dudley. I'm a Programme Manager from Kent, Surrey and Sussex Patient Safety Collaborative. Thank you for joining me today on this Restore2 and Restore2 Mini Training Awareness Programme. So today, through this presentation, I'd like to give you an introduction to the National Patient Safety Improvement Programme and my role within it, an overview of Restore2 and Restore2 Mini and Use2, and what are the benefits for the system in using the same tools. I'd like to discuss the role of primary care in supporting care homes for Restore2 and give you a brief update on the Kent position, including our digital beds monitoring system, and then have a look at what data could be used to show improvement if you do start rolling out Restore2 within your primary care network or GP practice. So as I mentioned, this is a National Patient Safety Improvement Programme, and I work for the Kent, Surrey and Sussex Patient Safety Collaborative, which is part of the Academic Health Science Network. It's a national programme and there's 15 of us working across the country to deliver this. And as I say, I'm covering this area, Kent, Surrey and Sussex. The programme's funded by NHS England, and it's aimed at spread and adoption of patient safety programmes. At the moment, there's 5 safety patient programmes running at the moment. One is around care homes, which is the managing deterioration in care home settings or non-acute settings, mental health and learning disability, and that's around reducing restrictive practice, medicine safety, system safety, and maternity and neonatal. And it's really around systems and giving us support for systems to continually improve. So I'm going to talk about both Restore2 and Restore2 Mini today. And just to talk about, the R stands for recognise, the E stands for early, the S stands for soft signs, the T stands for take, O stands for observations, R stands for respond, and E stands for escalate. And as you can see, as you'll see as we go through the presentation, there's 5 elements that really support care home settings to roll that out. And when I say care home settings, and I'll mention this again, we mean care homes, nursing homes, learning disability services, domiciliary agencies, and community mental health services. So really the whole spectrum. So a little bit about what people using Restore2 in care homes think about it. We hear stories that staff are empowered and get more confident using tools like Restore2, that it really helps when they're going to escalate up, and that they've got clear evidence of why they're doing it. They've seen staff using Restore2 becoming far more prepared, and they feel like they know what the GP is going to ask. They think OBS on a resident a day is a brilliant idea because it's reduced paperwork, and they just know their residents so much better than they did before. So what is Restore2 or Restore2 Mini designed to support people to do? It really helps people recognise when a person may be deteriorating or at risk of physical deterioration. It gives them the tools to act appropriately according to the person's needs. You can obtain a complete set of vital signs to inform escalation and have that conversation when you are escalating, particularly if you're using the full Restore2 version. Helps you speak to the most appropriate health professional in a timely way because it tells you how you'll be monitoring and how you should escalate, and gives you that tool to provide an escalation history to the clinical decision maker so that they're able to make the right decision. So it's really about getting staff and people the right support in the right timescales. And just to mention that all this information is on the Restore2 official website, which is at the Hampshire South and Isle of Wight CCG. So who should be using Restore2 and Restore2 Mini, and how does that interact with Use2? So the aim of it is to provide that common language across the system, regardless of where you're working within it. And Restore2 and Restore2 Mini should be used by care homes, nursing homes, learning disability services, domiciliary agencies and carers, where they really need to be able to demonstrate their knowledge of those soft signs and patient preference. And that interface with News2 comes through that communication. News2 is already mandatory for acute trust and ambulance services, and it should start to be used by primary care teams, community frailty teams, community nurses and other healthcare professionals. We already know that it's widely used by community teams across Kent and Medway. So they're already speaking that language with each other, maybe not always with care homes or other professionals. So what are the outcomes of using Restore2? What does it mean for the residents and the people working with them? So it supports carers to recognise early physical deterioration. So it's about that early detection. It supports a timeliness of response. So it provides a standardised assessment tool and a common language across health and care. And it's that competency of response. And when we go through the training with care homes, we give examples of where they've escalated through case studies that were from real practice, and that escalation hasn't been responded to effectively, and the consequences of that were very serious for the resident in question. So it really enables carers to communicate concisely with clinical decision makers to get that effective response. So we know that deterioration, including sepsis, is often recognised late and sometimes too late, and that length of time can have serious consequences for people needing to get a rapid response. So it would be really helpful if everybody spoke the same language and could communicate concerns in a more consistent and concise way. And that is how Restore2 is set up to enable that communication. So how can that help primary care, specifically working with care home residents and domiciliary agencies and people that interface with both of those? So we hear from our primary care colleagues that they sometimes have difficulty achieving concise, effective communication and escalation between care homes and practices. So Restore2 gives GPs information around full sets of observations through a News2 score, structured communication through the SBAR tool, which gives key information in a consistent and rapid way, and that residents have a baseline for what's normal for them, so that we can really see when that deterioration is happening and what pace it's happening at. We hear that the number of calls from homes to primary care can be overwhelming, and care homes call it telephone tennis as well, where they keep having to call back. So Restore2 helps care homes to assess who needs escalating and who can be monitored locally. And we'll look at how that works as we go forward. And it provides enough information for the GPs to triage and prioritise caseloads. So I won't go through this in detail, but you'll have these slides to look at outside of this presentation as well. But we hear from GPs that have actively worked with their care homes to deliver it, that it improves patient care, it reduces administration strain, and they have fewer inbound telephone calls, and the ones that they get, the information quality is much better. And again, it promotes that consistency of language across their patient's pathway. We hear from care homes that it saves time for carers, and in their words, that telephone tennis. It's a structured method of assessing a resident's communication with GPs, gives them less paperwork in the end, and it gives them a confidence across their care home in their decision making. We're not asking them to make clinical decisions, but their decision making of when they're going to escalate. And across the piece, we know that CQC is getting more interested in how the system is managing physical deterioration, so it can really help with the key lines of inquiries, both for inspections and pre-inspection returns in both ways. So thinking about that more closely, how would you link working with your care home colleagues with Restore2? In terms of SAFE, you can actively monitor for deterioration and take action quickly with your care homes. It can be effective and responsive because you've evidence of locally agreed escalation routes, and in time we'll be able to show how you've responded to residents' changing needs. You can answer the care inquiry by incorporating residents' personal care plans in escalation processes. And Restore2 is really well set up to work with things like respect and treatment escalation plans. And in terms of well-led, you can demonstrate you are continuously learning, improving practice and working well with other agencies across the system, both in a learning way and that shared communication. So thinking about the interface between Restore2 and News2 in terms of primary care and care homes, these are the tools, and we go through them individually in a moment, that would be used in your care homes. Whereas in the primary care, you'd be looking at the News2 scores and how it's escalated towards you via the SBARD. And we'll look at that more in detail, but this gives you an overview of how that communication would work across your service. So the very first, there's 5 elements in Restore2, in the full Restore2, and the first one is soft signs. And we work quite a lot during the training, the online training that we provide with care homes, to think about what soft signs means. And the importance of soft signs is that it really reflects each individual's needs. We hear a lot of the time that this is the kind of comment that comes to primary care or during escalations. I know something is wrong, I just don't know what. They just aren't themselves. So really this helps carers and support staff to really know the person well, work with them and their family to understand what their individual soft signs are, which is relevant to that person. Any changes to that soft signs will trigger a response, either escalation within your own care home setting or communication with your clinical decision maker, whether that's your GP, your frailty team or 111. But it would also send you to take a News Restore2 score and escalate that way as well. So you go back to your baselining, back to your News2, and see if there is any vital signs of deterioration as well. And it's especially important for people with communication difficulties. We saw that during COVID, that there was an inequality around how well people did during COVID with learning disabilities. And again, we can use opportunities like annual reviews to help learning disability services baseline their residents. So when we work with the care homes through soft signs, we look at it through 3 elements. People's mental health, and if there's any deterioration or behaviour change around that, their physical health, cold hands, mobility, and then we look at behaviours and abilities as well. Has something really changed? Have they become more angry or frustrated, or are they withdrawn? And we look at case studies to work through that. So we look at how it's been written up in one case study, and then we work through doing another one. So the next aspect of Restore2 is what's normal for your resident. And this is where the paperwork encourages care homes to document what's normal for their resident. And this is sometimes where primary care comes in as well. If there's a complex resident, they may need some support with some of the baselining around News2. And we'll hear Kim Gardner talking a little bit about that later. But again, this is where the treatment escalation plan links and respect links come in, so that the person's wishes work in conjunction with that and are demonstrated within the Restore2 paperwork. So it's really important in terms of baselining to know what is normal for that person in terms of their national early warning scores too. We talk a lot during the training that not every one of your residents will start from a position of 0, and we have several case studies that we can work through to do that. I think there's something about 15% of care home residents may start from a different position of 0. And the importance of treatment escalation plans and end-of-life care plans in documenting what's normal for your residents. Again, we really emphasise that actions can't always be ascribed to a score, and it may be that you need to go back to those soft signs and just take that forward, and that sometimes judgment is needed and conversations within the care home. But again, you'd be documenting that, and that the training that we give helps you realise if you've got a 0 score, you may still want to monitor that person for any more changes. We talk a lot about if it feels like a medical emergency, if you're suspecting a heart attack or a stroke, or somebody's had a serious injury, you dial 999 in the normal way. So this is one of the case studies that we work through. This resident is called Edward, and we talk about his News 2 score is quite changeable. He could be 0, but in the morning he might have confusions, and we talk through about what's a new confusion and what's a normal confusion. You can see here that his wishes are well documented, and then we work through another case study where the delegates have a go at plotting their own what's normal for the resident. So this is where the difference happens between Restore2 and Restore2 Mini. If you're using Restore2, which is designed for learning disability services, where maybe the people they're supporting wouldn't tolerate having a blood pressure cuff on, or maybe having pulse oximetry. And if you're using Restore2, you work on the soft signs, what's normal for the resident, and then you go on to the escalation tool, which is the SBARD. So you'd have those 3 elements. If you're using the full Restore2, this is when you'd start looking at the national early warning scores too. And we take through in the training, we go through each of the elements of this, and including how it's plotted. We do some work around what you would do if somebody had a lung condition like COPD. And how you still plot that. So we do some myth busting around that as well, because we do sometimes get challenged back that if somebody had a lung condition, you couldn't do this particular training, or you couldn't put that person on Restore2 or News 2. So we work around that as well, and we have a go at plotting it and how that would look and how you'd add it up. Then we also talk about each of the vital signs. There's 6 of them in the national early warning scores too, as you can see here. And again, you'll see these slides if you're not familiar with it, and how each is then given a number, and that's how you get your score up. We then talk about the next stage of Restore2 is escalation, once you've got that scale. And again, there's an assumption made that escalation, that 0 means that person is well. But again, we talk about that's not the case for everybody, and you have to be really personalised if you're using this model. We then look at escalation once you've got your News 2 scores added up, and we work on the 3, 5, 7 rule. 3 being that the person can probably be managed with support from your clinical decision maker, whether that's your GP team or your frailty team, within the community. And when you're working through the Restore2, it would talk to you about how often you should be monitoring that person. We then move on to if that person has a score of 5 and that the review then becomes urgent, you need urgent support from your clinical decision maker. Again, whether that's GP, out of hours, however you're going to escalate up in terms of your local escalation plan. And I think this really helps when primary care lead this with their care homes, because you can really review how everybody escalates. And then we look at 7, which is a very urgent review, and that that person providing, depending on what their treatment escalation plan or respect document says, would be likely going to hospital unless they're end of life care. We also talk about how high you can get up to 20 with the News 2 score, but that really by the time they're getting here, they're getting very seriously ill, and we have a case study again to work through with that. The final element of Restore2 is the SBARD, and that is your structured communication tool when you want to escalate. Again, through the training, we have a case study that we work through with a gentleman with diabetes that they suspect has got an infection which is causing his diabetes to be unstable. We talk about the S stands for situation, and how the care home or the person escalating sets a scene with that. We talk about the background where when you're escalating up, you tell what the person's long-term conditions might be, or any physical health conditions or mental health conditions and medications. We talk about assessment, why they're concerned, why they'll be escalating, and then they have an opportunity to give you their recommendations. Again, we say they're not being asked to be the clinical decision makers, they're just well placed to tell what differences are that patient or that resident has. And then finally, together, with their clinical decision maker that they're escalating to, they record decision. And in this particular case, it was decided that vital signs checks would be done every 6 hours until the GP was able to visit, and that they would collect a urine sample ready to go back with the GP. This is what the paperwork looks like within Restore2. So it's really super helpful for the care homes because they have prompts all the way through. They don't have to remember this. When they're calling 111, they may not be asked the questions in this particular way, but when we've talked to people that have received these escalations or have indeed done these escalations, those questions do come out, and at least a photocopy of this form can accompany somebody that might be taken to hospital or another setting. So there's that continuity as well. So I'm just going to play you a video now from Dr. Gardner. So they originally set up, Dr. Gardner worked with her care homes on a pilot for Restore2. They originally started with the paper version and then went on to a digital bed monitoring version with Docabo. So I'm just hoping this is going to play, so just bear with me.
Created a digital version of Restore2 to enable the carer to have a secure and reliable mechanism for transferring all the data, the questions, the soft signs, the vital signs that are present in Restore2 to a clinician in a safe and secure manner. And if any of those parameters are out of threshold, then an alert will be generated and the relevant clinician notified.
When we started with the paper format, obviously the care home would do the observations, and although they would impart some of that information to the receptionist who might hand it over with the details of the GP call, we didn't have that whole assessment available to us at that time. You were still dependent on phoning the care home, getting through, getting hold of the right member of staff with those delays, and then they would tell you all of the detail and you would make those decisions. With the digital and the Docabo, we now get that whole report coming through to us straight away. So it has really helped us respond more quickly when needed, but also I think give the right response.
With the Docabo system, we're able to complete the data online. That goes immediately to the local surgery. So you're effectively 24, 48 hours in advance. For staff, it's sort of, it gives them confidence to know they've done their very best for that person. We had a case here several months ago where we have a resident, it was an elderly lady who was suffering with COPD. It was quite late in the evening, whereas normally, I mean, the GP surgery will have left by 6 o'clock, 6:30. When we knew we needed some intervention, some sort of further medication for this lady, she was quite frail and quite poorly. We had a telephone call back within 5 minutes from one of the practice managers. The prescription went across to the local pharmacy digitally, electronically, and we had the medication before the end of day.
It made us confident, gave us the confidence, and supported the staff who work on the floor, how to escalate. The staff knew what needs to be done or what's best for the resident, how to react if they get unwell. So the resident's point of view, I think we as a care home managed to do the best for the resident, do the best quality care that we promise to the resident by using Restore2.
Quite easy to roll out once the initial workload of getting everyone's news scores initially was over. So when we first started using the News2 and Restore2 at Littlebourne House, we used it for a select 16 high-risk patients, and so then that got us used to using it, and then slowly we integrated it into the whole home and all the residents. It's been really positive, so it's nice to have the ranges there in front of you, so you know if you need to be concerned or not, and to escalate if needed.
Working closely with the Academic Health Science Network and Kenton Medway CCG, and indeed the PCNs on the project delivery side, has been really, really successful. We've had regular meetings to gather requirements, track progress, and delivered joint training sessions, and indeed helped to provide an extended support network.
I think the benefits are huge, and we're really pleased that with the pilot we did with Littlebourne House, without a doubt it saves clinical time. but I do think it enhances the care to the resident, and that is the fundamental thing for me.
So hopefully you could see from that some of the benefits that they found from using Restore2, both from a digital point of view when they were lucky enough to get on their Dockerbow trial, but also before that they started rolling out very early in COVID, so that they could really recognise deteriorating patients quickly. And the care home, with a little bit of support from the GP, was able to get on that system very, very quickly. So thinking a little bit about, and having talked to some of the people within primary care that have rolled this out, there's some ways that you can really help the care homes in your area get on to using Restore2 and prepare to get on to the next trial of the next tranche of the digital rollout, if that's what you'd like to do. So we really found, when we've spoken to primary care, that areas that have rolled this out, and we've done this in places across Kent, Surrey and Sussex, it's good to develop a process within the practice around Restore2 and Use2, so that people in the practice, whether that's people working on reception, your clinical teams, are ready to receive the SBARD and aware of what Use2 might mean and who they need to escalate to. So that really means thinking about training for all colleagues to understand the urgency of an escalation and to whom they'd be escalating. So the Restore2 training that's currently delivered virtually is free to anybody. It's rolled out twice a month, so that's quite handy for staff to come on at a time that suits them. Then I think it's about identifying which of your care homes have already adopted and embedded Restore2. We have got quite a few care homes across Kent, and I'll talk a little bit about numbers in a moment, that have already started using this and are escalating if they're that way, if they're doing emergency escalations. And then who have been trained but may need support in baselining. We know when we've gone back and talked to care homes, they may have done the training but feel a bit over-faced about rolling out. So it may be that they just need a bit of support around baselining and getting maybe a few residents on so they can start training their staff a little bit more. And then those who've not engaged at all. This sort of role is quite often being undertaken by care coordinators or the care home team, just to do that initial baselining of where the care homes are within your PCN. We take an asset-based approach as well. So things like learning disability services, they could use annual reviews where they're already working with you as an opportunity to baseline and introduce Restore2 Mini or full if applicable. And I did, when I first started this work, make a bit of an assumption that all learning disability services would automatically want to go to the Restore2 Mini, but I was corrected quite early on that some said no, the people their support would be well able to tolerate their vital sign checks. So it really just depends, and they used things like storyboards to get them to that stage. Then I think as well, if you've got the situation where they haven't engaged or they may need some more training, signpost the care home settings to our training at KSS PSC, Kent, Surrey and Sussex Patient Safety Collaborative, where we can do virtual training and we can point them in the right directions to where they can download their paperwork. Plan how you engage with the care home settings, and again the community nurses develop shared language. We know that the community nurses across Kent and Medway are using Use2, but care homes tell us they quite often don't have those conversations with them, so they're missing opportunities both for that shared language and also to upskill the care homes around their confidence in taking it as well. And to utilise Use2 and SBARD ward rounds, whether they're virtual visits, so that when you're communicating as well, you're actively asking for Use2 to help triage and get the care homes really acting and using that language as well. So thinking about this as a quality improvement piece, and wanting to understand what changes using Restore2 in your care home settings and those local escalation plans, what kind of data could you look at to demonstrate change? In terms of quantitative data, you could use things like number of calls to the practice. Did they result in a visit? Did they result in medication? Or did they result in telephone recommendations? And see initially whether you have a spike in those areas and whether you can see that improving as the care homes become more comfortable. A reduction in calls to emergency services, a reduction in conveyances to acute services, and even can you demonstrate a reduction in hospital stays under 24 hours, so somebody's gone in and they've been turned around quite quickly. In terms of qualitative data, faster and more informed ward rounds. So it might be that they become more effective and more efficient when you're actually talking to care homes in the same language, and everybody's aware of things like soft signs, news to baseline scores, and what might have changed for that patient, or that somebody's remaining quite stable but they're on the care home's radar. Better knowledge of residents, as we heard Kim describe. You get much better information, and where they've been doing this for some time now, they feel they really know the residents in their care homes that they're aligned to. Joined up working and shared communication, you can demonstrate that. And again, vignettes like we heard from Littlebourne, and we've got plenty of those from places that haven't used Docabo and are just using Restore2. And again, this information, once you've recorded it, is really helpful for your provider inspection returns or collections if you're in primary care to the CQC, and again for your care homes as well. And we'd be happy if you wanted us to escalate any of those stories to NHS England as well. So just looking at the training that we provide as well, I said it's very much case-based studies, and these are the case scenarios that we work through, and all this information is on the website, if that's helpful. We use training videos, and they can be accessed again at any time. And if you want to make a formal training around News 2 for any of your colleagues within the practice, the RCGP provides free training around that online, and you can get a certificate at the end of it. Again, those links are at the end of this presentation. And these are some of the tools that can help you understand how far along your care homes are with their adoption scale. There's competency checks if your clinical decision makers want to know how confident the care homes feel with the vital sign checks and their Restore2 paperwork. And there's handout books and monitoring tools for them. And this is what the paperwork looks like on the front page. And again, that's fully downloadable for free from the website. So I've put those tools in links within this presentation so that you can go and look for those when you're ready in your own time. So I said I'd briefly update as well about the position in Kent so far. We've got somewhere around 620 care home settings across Kent and Medway. We know around 54% of those care homes have an awareness of Restore2, and 47% have shown an interest in Restore2. And within that, some of them are fully embedded, like we saw with Littlebourne, that have been using it for some time. The picture of adoption, though, is quite unclear. We have low reporting on the National Capacity Tracker in Kent and Medway, around less than 20%. And we really rely on support from the local authorities through their annual quality checks, feedback from people like care coordinators, as well as looking at our own training records to get that picture, but it's still not totally clear. So we could be underrepresenting that. But also we have found that sometimes where they're not supported by primary care, care homes start using Restore2, and then with staff churn, they've stopped using it again. So that can be a real risk for us going forward. Again, it might be an underestimation, because some providers have accessed this through conferences on their own and independently accessed it. Others have asked for signposting and gone to the websites and directly trained. So again, this is very much caveated by it's a very much a ballpark figure. What have we been doing to improve the uptake for Restore2? We provide bi-monthly virtual training sessions. We do in-person events at the Digital Innovation Centre in Hawkinge. We've done quarterly care home networks virtually so people can keep updated. We work at ICB levels with the local authorities and place-based leads, and we're developing new ways of learning and accessing learning. That's simulation and scenarios, which is quite new to adult social care and quite innovative. And we do that at the Digital Innovation Centre, and we're working with them at the moment and hopefully hoping to launch a social care digital learning platform so that people can access this training at a time that suits them in small chunks. So hopefully that will increase uptake and make it just more accessible, really. We supported the monitoring care homes beds pilot with Docabo and the ICB, and I'll talk a little bit more on that in a moment. And we'll be supporting the next wave of the digital beds monitoring work, including helping PCNs to write their expressions of interest around this piece of work. So what does the monitoring digital beds look like that Kim and Littlebourne were talking about? So it's the care homes baseline, sometimes with primary care support, all the residents within their setting, so that they have what's normal for that resident digitally enabled already. They do resident of the month, but also if there's anything concerns, anything that changes in soft signs, they can automatically go back to their baselining and their resident of the month. They've already got a history, and then look and see if there's any changes to that person's vital signs. Once they put that in, it automatically goes to the GP in a report. It's the SBARD report, and anything over a 3 automatically goes. They can change it if that's not normal for that person, so there is an override, so you wouldn't get lots of unnecessary reports, and then that can be dealt with in the practices system as well. There's lots of training that goes around this before you take it up, but there is an expectation that people putting in an expression of interest would already have Restore2 embedded within their practice and the care homes that they're putting forward to work with, and it's well embedded across the PCM. But the training comes in 2 parts. So there's specific training packages for the care homes, and there's specific training packages for the PCNs, and Docabo come out and deliver those. And so everybody's clear on the standing operating procedures and those, how quickly you would expect a call back from your practice within those times. And again, this is where you can get that learning around national early warning scores. There's a link there for it. So as I said earlier, here's all the links for all the training that I've talked about today, and my email is up there. So if you've got anything you'd like to ask, please feel free to email me, or happily send a list of questions and I can take them back and answer them. If I don't know the answer, I can hopefully find somebody that does. But again, happy if you want to talk about anything that I've talked about today or have any other questions. Thank you very much for listening.